This will be part 2 of Chapter 14, Sexual Dysfunctions and Sex Therapy. We'll pick up where we left off, talking about erectile dysfunction, then we'll move on to sexual dysfunctions that involve pain. We'll finish up the chapter with a discussion of sex therapy. Now with erectile dysfunction, and for most of us, we've been kind of inundated with advertising for more than a decade now, probably more like 20 years, of medical treatments for erectile dysfunction, primarily involving medications such as Viagra and related drugs. We need to look at kind of the range, though, of biological causes of erectile dysfunction. Vascular diseases are probably the number one factor that predicts that leads the list of biological causes. Heart disease, high blood pressure, and in some cases it's the medications used to treat those diseases that compound the problem. There are also neurological conditions that can precipitate ED, trauma or surgeries to the pelvic area, for example, prostate surgeries for prostate cancer can create ED. Hormonal problems, and in some cases thyroid disease or treatments for thyroid cancer can lead to erectile dysfunction. A variety of prescription drugs can cause erection problems, and as I believe I mentioned in the last presentation, alcohol abuse can lead to ED. There are psychological causes of ED in some cases. Sometimes it's a cyclical problem where you have stressors or performance anxiety or depression that can lead to interference with performance, and that can lead to more anxiety and more concern and more performance anxiety. Some men report also they feel like they have to rely on ED treatment or ED medications in order to perform sexually, and that exacerbates their stress or their concerns about their ability to perform. Treatments for erectile disorder, and I pulled this information from a foundation called the Urology Care Foundation because I wanted the most up-to-date information. They list a variety of medications that you're probably familiar with from advertising. In the United States, there are medications such as Viagra, Cialis, Levitra, Stendra. They're tweaked every now and then by pharmaceutical companies, but they've been available and are well understood in terms of their effectiveness. Testosterone therapy is recommended if a person tests low in testosterone, and that can be effective. In some cases, penile injections are recommended with particular medications that can increase functioning. In some cases, people will use vacuum erection devices if they are having trouble getting an erection started. Those devices can help make sure that that process proceeds. Penile implants and surgeries are a little less common because they are invasive, and responses to them are mixed. So depending on the nature of the problem, biologically and psychologically, different treatment approaches will be tried. And that really, stems from having a high quality relationship with your urologist and other healthcare providers in order to choose the approach that works best for you. Female orgasmic disorder, and I pulled this information from the International Society for Sexual Medicine. Again, I wanted to try and find information that went beyond what was presented in your text and that could enhance your learning. Female orgasmic disorder is sometimes controversial if you look historically at how women's sexuality has been conceptualized in psychology and in medicine. It's often been kind of characterized as always being compared to the male model, and social expectations of what women should be and what they should experience are sometimes in stark contrast to what women actually describe about their own sexual experiences. Female orgasmic disorder has a controversial history as a result, and some of those problematic elements are still kind of playing themselves out. So kind of keep that in mind as we move forward here. Female orgasmic disorder is described in the clinical sense as persistent recurrent difficulty in experiencing orgasm, even when sufficient stimulation is provided, and when the person is sufficiently aroused. So if you look at survey data, and the high percentage of women who report having difficulty achieving orgasm, or report low percentages of having orgasm during sexual encounters, the majority of those cases, this standard is not met, because what women report in surveys is that most of the time it's because they have not engaged in sexual encounters that involve sufficient stimulation. So if we kind of take that off the table, these are cases where women report just having difficulty attaining orgasm experience. As with the other disorders that we've discussed, you have to have a minimum of 6-month experience and the experience of distress. The orgasmic disorder is the second most commonly reported sexual dysfunction for women, at least in the United States. It's estimated to affect a fairly significant percentage of women in the United States. In Asia, in some other countries, the rates are far higher. Now, one thing you should keep in mind, and I'll go back to bullet point number 1, where you have that contingency that says following sufficient stimulation and arousal, it's difficult for researchers and for clinicians to ascertain whether or not that criteria is actually being met. So you may be looking at those 16 to 28% of women in the United States, Europe, and Central and South America, and say, wow, that's really high. And you would be right to have that reaction. And again, for clinicians and researchers, it's challenging to determine, based on patient interviews and other methods of research, how women themselves are operationalizing sufficient stimulation. For example, it's not uncommon for women to come into their physician, if they bring it up, which is a big if they bring it up, they may believe that simply having penile-vaginal intercourse should be sufficient stimulation. But upon further discussion, once they are provided with enough education, they realize that if they get sufficient clitoral stimulation, that the problem is addressed. So those percentages need to be taken in that context, that it's often difficult to ascertain exactly how people are kind of defining that concept of sufficient stimulation. Now, there are lots of potential causes on the physiological side, and clinicians are going to start with a physical exam, try and rule out physiological explanations for the person's description of their difficulties. There's some physiological conditions that can affect orgasm function, neurological problems, cardiovascular disease, cancer, urogenital disorders, and so on. There are also, though, psychological, sociocultural, and interpersonal problems that people can face. So clinicians, and usually when women bring this up, it's with their OBGYN or their family practice provider. The physiological is going to be ruled out first, and then followed by a discussion of the other factors. Hopefully with a referral to a psychologist who has experience with female orgasmic disorder. So some of the psychological challenges, female orgasmic disorder has been associated with depression and anxiety, with a history of sexual abuse or physical abuse, with stress, and also with substance use disorders. Some of the interpersonal problems can have to do with sometimes the sexual dynamic between partners, as it's listed here. Um, Partner performance and technique may mean that the female in the relationship is not getting adequate stimulation. For example, not getting enough clitoral stimulation to reach orgasm. In some cases, um, with female orgasmic disorder, especially if it's situational, the woman may report that she can't achieve orgasm through self-stimulation and she currently lacks a partner. Um, Relationship quality, relationship conflicts can be a problem. And if people lack privacy, and you may be thinking, what does that mean? There are lots of people who don't have adequate privacy for sexual interactions, and that can be very inhibiting for some people as they experience their sexual encounters. There are also sociocultural influences. I mentioned earlier that sometimes when clinicians talk to women about orgasmic disorder, what they find is that women sometimes just don't understand how orgasm um, works in terms of stimulation and what might be required for them. So they often lack education, and that kind of education about the physiology of orgasm and some encouragement to explore their own, particular unique physiology can be very helpful. There are also, religious and sociocultural kind of values and ethics that can suggest to women that they shouldn't experience orgasm, or if they do experience orgasm, that there's something deviant or dirty about them. There are also a variety of societal taboos. In some cultures, women who derive a lot of psychological and emotional pleasure from sex are seen as somehow deviant. So there's almost a cultural taboo on the sexually experienced and sexually involved female. Treatment of female orgasmic disorder, and again, I've taken this from the ISSM, it depends on the cause. If the biological causes reveal some things that can be treated on that end, then that is the course that's often taken. If biological causes have been ruled out, then counseling and sex therapy are common routes to success. If the patient is dealing with depression and anxiety, those should be treated concurrent with dealing with relationship problems and issues of past abuse. Therapy can also be used to improve the functioning of the couple or the parties in the relationship, often focusing on communication and also practical sexual habits. A sex therapist may make suggestions for various and sometimes very specific techniques, such as self-stimulation, and also using techniques that involve more clitoral stimulation and more time. Women may learn, as I've just mentioned, different ways to masturbate or to self-stimulate to reach orgasm, either with a partner or without. And couples can be encouraged to expand the types of sexual interactions that they have and the practices that they use. Often, exploring new and different ways to provide pleasure to each other. Some specific techniques, sensate focus is one that is often mentioned because it focuses on the couple or the partners really engaging in intimate touching that is non-sexual at first, but gradually moves in the direction of sexual touching. So sensate focus can help couples to slow the process down, to really focus on giving each other a great deal of physical contact before they move into actual sexual contact. Now, the next couple of disorders that we're going to look at are genitopelvic pain or penetration disorders. Um, Most of the time you're talking about females with this disorder, but in terms of some of the disorders that fall into this broad group, men can experience pain disorders during sex as well. So we'll start with just the general definition. Genitopelvic pain penetration disorder, which is a long, complicated name, but what it refers to is significant pain and difficulty with penetrative vaginal sex. So you're talking about penile vaginal sex or penetration with toys or devices. It's an umbrella term for two categories of sexual disorders, sexual pain disorders, which in themselves there are some subcategories. Dyspareunia is painful intercourse, and in that case you can have both males and females who experience that, and vaginismus, which is specific to females, where the muscles of the vagina become so restrictive that penetration is difficult and often painful. So we'll start with vaginismus. Here you have recurrent involuntary spasms of the muscles in the vagina, and it interferes directly with penetration. Women report that they typically are still sexually aroused, they enjoy sexual activities, and they can achieve orgasm through activities such as oral sex or through self-stimulation and masturbation. But what is specifically painful for them is penetrative sex. Treatments vary. There are you want to start with, as is typical, looking for organic causes such as endometriosis, for example, or fibroids that are causing restrictions, inflammatory disorders, and other kinds of organic causes. Beyond that, teaching women to insert a device called a dilator or other objects that slowly increase in size, simultaneous with learning relaxation techniques to kind of retrain the body to respond in a non-restrictive, spasming way to penetration. So, for example, a woman could be provided with a series of increasing in size devices that she can insert while practicing her relaxation and breathing techniques in order to desensitize. So that's where systematic desensitization comes in. Also, simultaneous with that, many women will be prescribed Kegel exercises, which involves systematically engaging the Kegel, the pelvic floor muscles by contracting them voluntarily and releasing them. And that can strengthen the musculature, but it also strengthens a woman's perception that she has voluntary control over her pelvic floor muscles. Therapy may also involve cognitive aspects. When sex is painful, it's often difficult to maintain positive emotions and positive thoughts about sex and sex with a partner. And the therapies often take place individually, but they may take place with a partner. They may either come simultaneous with or before insertion training. Insertion training refers to that gradually increasing size of insertion devices to help women kind of retrain the brain, retrain the body to accept a penetration. Dyspareunia is recurrent or persistent genital pain that's connected to intercourse or attempts at sex or attempts at penetrative sex. This is one of the more common sexual dysfunctions reported by women under 40. And the pain that's reported is often at the start of penetration, or it can occur with deep penetration, or both. the pain may happen with only certain partners, or it may happen in certain positions. For example, with deep penetration, a person may report pain only with rear entry penetration, which can be connected to kind of the shape of her anatomy and the size and shape of her partner's penis. In other cases, side positions or other kinds of positions may be problematic. There are lots of different causes. As I mentioned earlier, males can also experience pain on penetrative sex. It's somewhat less common than that reported for females. For females, one of the reported problems is inadequate lubrication. So if you are a perimenopausal or menopausal woman, you often will experience a loss of lubrication. Therefore, it's important to add lubrication in order to maintain the comfort of penetrative sex. Lack of estrogen may be what's driving that reduction in lubrication. Lack of estrogen also can cause the tissues to respond differently to sexual encounters. Infections and inflammation due to a variety of causes, including endometriosis, can cause pelvic pain. Allergic reactions and other medical conditions can also cause pain. Allergic reactions can be to things like spermicides or lubricants or other kinds of substances. It could be allergic reactions to the makeup of condoms, for example. Medical conditions, there's a very wide range that can be associated with pain on intercourse. Sometimes it's because of birth control devices such as cervical cups or IUDs that are not properly inserted. Painful sex can also be connected to relationship problems and emotional difficulties that people are having. Vaginismus is a correlated dysfunction. Pain and muscular spasming of the vagina can also be associated with dyspareunia. There can also be anatomical issues. Having a tipped uterus, having scarring or intrusion from endometriosis can cause painful intercourse under certain circumstances. And also if there's been physical trauma to the genital region or internally due to treatments, surgeries or treatments for various diseases. For men, when they report painful intercourse, painful penetration, it's often due to inflammatory conditions or lesions on the penis or injury to the penis. Peyronie's disease is one possible cause. Urethritis or inflammation of the urethra is a possible cause. On the psychological side, trauma, guilt, anxiety, depression are associated factors for males. And some of that can sometimes be connected to males' experiences during their upbringing with religious or parental rules against certain kinds of sexual activities, particularly penetrative sex. So those factors may come into play. Finally, relationship conflicts. Just like as is the case for females, relationship conflicts can kind of turn into pain on sex. Now, treatment, if there are biological factors, you have to pursue those biologicals and attempt to correct them or treat them. So there will be a full evaluation of medical condition. In some cases, if you're talking about someone who's experiencing depression and anxiety, antidepressants could be used, but there are a variety of other kinds of treatments. If there are physical issues, anatomical issues. There are some cases where those can be corrected. In some cases, using short-term treatments like lidocaine ointments or other kinds of approaches can be helpful. If the problem is anatomical, using different intercourse positions and avoiding positions that cause pain would be recommended. And teaching people to use other kinds of sexual activities that are fulfilling. The psychosocial factors, as you might guess, are typically treated through therapy, through individual psychotherapy, through couples therapy, through sex therapy, which often involves teaching people to monitor their thoughts, to replace negative thoughts with positive ones. One thing that's helpful in understanding these pain disorders is that pain has a cyclical, interactive relationship with our thinking, with our thoughts, our emotions, and our behaviors. So if you are anticipating pain, your body is going to respond to that in a very visceral way. Think about the last time you went to the dentist and you knew you were going to have a painful procedure. Your body is going to go into a bit of a fight or flight mode and start to prepare you for that pain. After that, since your body has kind of revved you up and got you ready for a painful experience, your body is going to, if you're talking about vaginismus experiences, the body's response, since the anticipated pain is in the vaginal area, the body is going to tighten those vaginal muscles. It will be involuntary at that point. That tightness makes sex painful. It may in fact make penetration impossible. The pain then reinforces that reflexive response. So if you go back to number 1 on this circle, your body and your mind are anticipating pain. That causes fear and anxiety. Your body responds to that anticipation by tightening in preparation for the pain. That preparation makes it even more painful, and it may prohibit penetration. The experience of more pain in response to that then intensifies the response. So your body tightens even more, braces even more on an ongoing basis. That can reinforce the avoidance of intimacy, the avoidance of sexual encounters. So something that therapists may work with their patients on is interfering with this cycle of pain. So if you go back to number 1 on the cycle, a therapist may work with a client to learn to inhibit that anticipatory response through cognitive therapies, through cognitive behavioral therapies. At number 2, people may be taught relaxation techniques to inhibit that tightening and bracing response. At that point, if the person starts to have less painful, more positive sexual encounters, the pain reinforcement cycle is interfered with, it's interrupted. So the body can react not by bracing, but instead by relaxing. Again, people will be taught relaxation techniques that will enable them to interfere with that bracing response and allow the body to relax. And that allows them then to move into more voluntary, more initiated acts of sexual intercourse. Now we're going to turn our discussion to sex therapy. Judging from your reactions to the discussion threads about sex therapy, as I kind of expected, most of you reported, broadly positive attitudes towards sex therapy, but feeling very resistant or very uncomfortable with the idea of you at your age seeking sex therapy. So I thought I would spend some time here just kind of demystifying sex therapy. People often have very weird ideas about what sex therapists do. Part of that can be based on some stereotypical expectations that you come into an office and you have sex in front of a therapist. That's not what happens. So we need to spend some time kind of demystifying what sex therapy is. So first, what are sex therapists and what do they do? And I've taken this again from the ISSM. Sex therapists are healthcare professionals. They provide counseling to individuals who are facing challenges in terms of emotion, cognition, and behavior related to sex. Sex has a physiological side, but human beings have great big brains. A lot of you've probably heard the saying that the biggest sex organ is the brain. So when people feel anxious, when they're stressed, their sexual relationships can suffer. Also, when people have been sexually traumatized, their fears, their negative beliefs can also lead to dysfunction. So what do sex therapists typically work with their clients to resolve? Erectile dysfunctions, premature ejaculation, performance anxiety, some of the things we've just talked about, painful penetration and vaginismus. But they also work with their clients on more psychosocial issues, communication issues, previous sexual abuse, gender identity concerns, orgasm difficulties, and relationship problems. So what happens during sex therapy? Sex therapy is intended for individuals and couples to work through their sexual difficulties. Depending on exactly what that is, it may be the individual is the focus of counseling. It may be that the couple is the focus of counseling, or maybe both. Clients usually come to a therapist's office. Sometimes, as I mentioned before, clients come in individually, sometimes with their partner. How often they do this, and specifically what's done during those meetings, depends on the type of problem that's being addressed. The ISSM argues that it's typical for people to feel anxious. I would say people report feeling anxious seeing any therapist. You're going to a person and you want to talk about very personal things. Sex is very personal, so it's normal to feel anxious. Many people, as you've all mentioned several times in class, report feeling nervous talking about sex. It's kind of taboo, and discussing it with a stranger may be even worse. Some people report the opposite, though. You're seeing someone who's not involved in your life, they're not your friends, that you don't have to worry about being embarrassed when you encounter them later after telling them what you're struggling with. So in many cases, people report being very relieved. They've talked to this therapist, they've told them what they're going through, and instead of being responded to with shock or disgust, they are responded to with acceptance and real rational explanations and potential solutions. So the start of therapy is going to be with a thorough kind of history being taken. So talking about health and sexual background, what people know, what their education is, sort of their belief system about sex, and their specific concerns. It's important that you understand, unlike the stereotype, unlike what some TV shows seem to suggest, sex therapy does not involve sexual activity. It doesn't involve physical contact. Clients do not have sex with sex therapists. That is a figment of fiction. Clients who feel uncomfortable with anything that's going on in their therapy sessions are encouraged to discuss it with their therapist. But be clear, these are not sex mentors. These are not people who are there to teach you how to have sex by having sex with you. That's inappropriate and it's illegal. There are paraprofessionals, they are not sex therapists, who do the kind of coaching that I've just described, but that is not a therapeutic technique that's governed by certification. Sex therapists are notorious for assigning homework. So these are practical activities. These are activities that sometimes have a very cognitive behavioral bent to them or a mindfulness bent to them. You know, if you're a person who's experiencing painful intercourse or difficulty with penetration or orgasmic difficulties, learning some mindfulness techniques, learning some relaxation techniques, and also learning self-stimulation techniques can be very, very helpful. Also, couples can be assigned homework, and they will be expected to come back to therapy and report the impact of their work over the period between sex therapy visits. How do you go about finding a sex therapist? Um, one Frequently, the first place that you get a recommendation for a sex therapist is from a physician. So for women, their OBGYN. For men, it could be their urologist or their general practitioner. Sex therapists can also be found by searching through professional organizations. I've posted the website for some of those organizations on D2L. And it's important, I think, you know, this is personal opinion, it's very important that you go with licensed, certified professionals who have a history of ethical practice and a history of providing services to clients. And that's why going through either a doctor referral or through a professional organization can be helpful. The rapport is really important, and this is true in any kind of therapeutic relationship, not just for sex therapy. You need to be comfortable with the person you're going to have a client-therapist relationship. You know, the way I look at it, you need to be able to sit across the room from a person and tell them honestly how you're feeling and how you're behaving and how you're thinking. It may be entirely possible that the first person or even the second person you attempt to develop that rapport with just does not work. So you should move on and find someone else. Some homework examples. I mentioned earlier sex therapy often involves practical practice. And I pulled this word from the ISSM website. Couples and individuals are often encouraged to experiment, to try new activities, to try role playing, to try toys, particularly if they're finding that arousal is a problem. Doing that kind of experimentation can increase arousal and kind of increase the playfulness and the joy that comes with sexual experimentation. Experimentation may also involve encouraging people to try new positions or techniques that they haven't tried before. Sensate focus is a common tactic that's used. I described this earlier. It's designed to help build intimacy, to build trust, simultaneous with letting the anxiety come down several levels. It starts with non-sexual touching. It progresses to sexual touching, eventually to intercourse for the parties. And that may take, you know, a good amount of time for people to learn that practice. In some cases, therapists will kind of prescribe, in quotes, a step-by-step process for sensate focus. Frequently, the homework involves simple education. If clients, and this is very common, come into sex therapy and there are blank spots in their knowledge of their physiology, of their anatomy, of their understanding of sexual response, they may just not know enough to correct some of the problems that they are encountering. So therapists may assign handouts, books, content, even videos, so that clients can learn more about their bodies. And in many cases, that can simply correct the problem. A therapist friend of mine reported an example where a couple had come in for couples counseling, and one of the problems they had was that they had not consummated their marriage. Neither of them had had sex before marriage. Now they were married, and they had made some attempts but had never successfully had intercourse. And they were very frustrated by this, both of them. What she found in therapy with this couple was that neither of them really understood how how sexual response worked. They didn't have a good understanding, for example, that it's helpful to engage in foreplay, to create a level of arousal that would allow the male in the relationship to maintain an erection, and for the female in the relationship to have sufficient arousal to have lubrication that would allow penetration. So by simply educating them and assigning them some sensate focus techniques, they were able to overcome the problems that they had, and they were able to have a very successful and satisfying sexual encounter. Also, lots of times sex therapists will give homework that involves practicing good communication. And a lot of that involves teaching people to ask for what they want and to explain what they don't want, and to do so very openly and clearly and without judgment. Sometimes those relational patterns have gotten so entrenched that they need to be reversed or replaced with more mindful, more empathetic, more effective communication strategies. So I found an article, and I've posted the link to the article on your D2L page, called Sex Therapy for the 21st Century. Someone had asked, I think it was on Perusal, about what are the trends in sex therapy more recently, and I had noted that in your text there's a lot of historical coverage. Where did sex therapy come from? What kind of tactics were used? And you're given several of those. So I found this helpful. This was actually a CE presentation for continuing education, and the author Weir has summarized some of the changes that have been in the offing in recent years. So the start, Weir notes that many of the techniques like sensate focus are still being used today because they work. Approaches, techniques, tactics, homework, things that have proven effectiveness are going to stick. But there are current researchers and practitioners who are pushing new approaches. Sexuality is more and more in the current period being considered to be an important aspect of general health, and to be wrapped in with our sense of mental health as well. And that's important to recognize because more general practice doctors, more OBGYNs, more psychotherapists, more counselors are really giving specific attention to sexuality and sexual health as a part of their practice. Weir argues that as a result, since sexuality is a significant component of your general physical and mental well-being, practicing psychologists are more and more often being educated more fully in human sexuality and techniques for sex therapy. There are specialists in sex therapy, and most of what I described earlier is information about those specialists. But all psychologists are increasingly being trained in order to provide guidance and solutions for their clients when those issues arise. So what are some practices that are emerging? As with all of psychotherapy and counseling, we're seeing more and more mindfulness-based interventions. Mindfulness is an approach that is in part relaxation and breathing techniques, and then also meditative practices that can really be very helpful for arousal issues, for pain issues, for cognitive interference that causes orgasm, and so on. And also for problems that need to be resolved after medical procedures, such as surgeries. Psychotherapeutic interventions are have been proven to be effective and are now being seen as, in many cases, things that can be paid for without so much argument as being necessary medically. So for example, ED therapies that are psychotherapeutic in nature are now more likely to be covered as medically necessary than they were in the past. There's also a trend, a very strong trend, in the direction of inclusivity. So most of the historical sex therapy approaches, especially those that are described in your text, were decidedly heterocentric. They were designed around the assumption of male-female dyads having sexual intercourse, and primarily penetrative sex that's penile-vaginal. So there's much more inclusion now, looking at varying sexual orientation and gender identity. Specific areas of expansion in sex therapy now involve transgender people, people who are non-binary, people in same-sex relationships, and in polyamorous relationships. Most approaches continue to focus on the individual rather than the couple. So, and that's in the past, but also currently. So the trend now is looking at both individual factors, but also wrapping in the relational issues that can exacerbate sexual performance and sexual experience difficulties. Think about it this way. I can teach you lots of techniques, but if some of the problems are in your relationship, you're going to go back into a troubled relationship, and all of the techniques that I've taught you will be for nothing. And finally, sex therapy is having to catch up to greater changes in attitudes towards sex. And what that means is we're a culture that's becoming more open, but we are also a culture that still has very, very mixed messages about sex and sexual difficulties, sexual dysfunctions. You know, as some of you mentioned in your responses on the discussion threads, you felt like, yeah, sex therapy is a good thing, but I wouldn't feel comfortable talking about it with my friends. So you need to really think about that. Why do you feel that way? And part of it is because while there's more openness, there's more inclusion, we're certainly surrounded by images of sex and sexuality all the time, but still we have this kind of hung up set of mixed messages. And sex therapists report having to incorporate those issues into their work as well. So that concludes my coverage of this chapter on sexual dysfunction and sex therapy. We'll see you next time.